Thank you to be all of you at your yellow seminar. Today, we are pleased to welcome Dr. Nikolaj Torp, a postdoctoral researcher at the Odense Liver Research Center in Denmark at the Odense University Hospital, and he is a resident in Gastroenterology and Hepatology at Odense Hospital. Dr. Torp completed both his medical degree and PhD at the University of Southern Denmark. He has co-authored more than 25 publications in the field of steatotic liver disease and decompensated cirrhosis. His research focused on clinical hepatology, particularly the use of phosphatidylethanol, or PTH, as a direct alcohol biomarker in steatotic liver disease. He is also interested in predictive biomarkers of response to human album therapy in patients with decompensated cirrhosis. So please join me in welcoming Dr. Nikolaj Torp. Nikolaj, the floor is yours. So.
Thanks a lot, Pablo, and thank you, everybody, for being here and for the kind invitation. So I'll just start to share my screen so we will have the technicalities in order. I hope you can all see it by now and that you can all hear me.
Yes, yeah. We can hear you, and also we see the presentation.
Perfect. That's great. That's great. Okay, so I will keep my, my own introduction very short, as you've already done it very nicely, Pablo. So thanks a lot. So my topic, or the talk of today, will be about phosphatidylethanol, or PEF, in steatotic liver disease. So for many of us, this is a relatively new biomarker that has become available as a direct alcohol biomarker, and us and many other researchers in the field are kind of accumulating the evidence of how we can and should implement this biomarker in the management of patients with steatotic liver disease. So my talk will be split more or less in two. So I have allocated around 45 minutes to the presentation itself, and I've left 15 minutes where I hope we can have a nice discussion and also time for questions around the topic and theme of PEF in steatotic liver disease. So what are kind of the objectives that I would like to go through, and what you will hopefully take away from today is the PEF fundamentals. So what is the kind of biochemical and technical basis of the measurements of phosphatidylethanol? Secondly, how should and do we interpret PEF results in patients with steatotic liver disease? What are the cutoffs that we apply? What are the pitfalls in interpreting a PEF value? And finally, what do the current data suggest when we talk about PEF in steatotic liver disease? And finally, I will open the floor of how we should put PEF into clinical practice. So when should we actually do the test, and how, very importantly, do we communicate the results both before we order the test, but also when we have the result in front of the patient? So this is more or less the menu that you have in front of you for today. So I hope you look forward. The first thing to open all this is a small case that I would like to bring forward, maybe kind of to have your engagement into the everyday patient that we see and how difficult it can actually be to classify these patients into this steatotic liver disease nomenclature. So what you see right here in front of you is more or less a textbook example of a MASLD patient. So we have a patient, a male, that is 56 years old, elevated BMI in the obesity class, recently diagnosed with type 2 diabetes, also has hypertension, dyslipidemia, where they get relevant medication for this. There's done a workup where we have marked steatosis and no focal lesions. We have a cap from the FibroScan and also some liver stiffness measurements indicating that there is fibrosis accumulating in the liver of this patient. We have some blood tests results with the elevated AST, GGT, but normal platelets and normal INR. And finally, the alcohol workup for this patient for other etiologies are all normal. So from all the things that I've said until now is probably what all of us will think of as a MASLD patient. But then we come to the alcohol, so the self-report of alcohol. And this is really as much an art as it's a science, how you should really come into the alcohol and ask about alcohol. But in this case, you can see this patient reports a glass of wine with dinner sometime, but it varies anywhere in between 4 to 8 drinks or units most weeks. And this is really, the question for all of us, because this is where it becomes difficult. So when we have this 4 to 6 drinks a week, we really put these patients in between the boundary of MASLD and to mid-ALD. And the label that fits this patient depends on the number that we, at least from this example, don't have yet. So this is one of the things, or in one of the scenarios where PEF can really be informative when we have to subclassify our patients. I guess most, if not all of you, are aware of the new steatotic liver disease nomenclature. So where we really have, in the presence of cardiometabolic risk factors on hepatic steatosis, alcohol consumption as the delineating factor between the patients with MASLD, mid-ALD, and finally ALD. So with this new nomenclature, we probably got made more aware in the way that we categorize our patients, that most of them don't, only have obesity, type 2 diabetes, for example, or alcohol. In many cases, we actually do see both. And that's something that would at least try to be acknowledged with the mid-ALD subclass of patients. But we also know that there are some clinical gaps when we try to classify these patients with steatotic liver disease. So what is often really the clinical gap in this scenario is the self-report. I think all of us in our clinic have experienced some of the issues with self-report. One thing is what the patient report. The second thing is actually also how we ask our patients about alcohol consumptions. This issue is not new. What you see from here is a figure from a study done in Toronto in Canada, published in Lancet back in the late 70s. And what you see from this figure is actually patients who have self-reported alcohol intake, which were in total 37, but who all had ethanol present in the urine, indicative of recent alcohol intake. And what was more or less interesting from this study, and what is also what we see today, is that when people are asked about drinking, some say that they never deny drinking when they do drink. That's one group of patients. Some say they drink all the time when we see them, and they deny all the time and say that they don't drink, but we find the alcohol in the urine. And finally, we have those in between where they sometimes say they drink and we find alcohol in the urine. Other times they say they don't drink and we also find alcohol in the urine. So this really shows what we are kind of fighting or challenge with in the clinic, that it's not always accurate when we asked about the alcohol intake and alcohol intake habits. And the second big issue that we have in the clinic is a lot of the indirect markers of alcohol consumption are really insufficient for moderate intake. So what you see here on this graph is actually data from a Swedish study published now close to 10 years ago. And what they did was that they randomized healthy adult individuals into either drinking 1 to 2 glasses a day for 3 months or staying abstinent for 3 months. And what they tried is that they tried to use many of the indirect biomarkers that we have of alcohol intake. So for example, ALT, AST, GGT, or the AST-ALT ratio, to see could these parameters really distinguish the patients who were randomized to drink 1 to 2 units a day or to the ones who were supposed to stay abstinent. And the conclusion from this was really that it could not. So these are the AUC values for all these different biomarkers, and the AUC of 0.5 is the same as flipping a coin. So you could see that none of these were really not that much better than flipping a coin. So that was, and still is, really one of the challenges that we have with many of the indirect biomarkers. When we talk about moderate intake, they're not really sensitive enough to capture this alcohol consumption. And that puts us closer to where the talk will go on from now, is that we need better and direct alcohol biomarkers to really have a true biochemical assessment of recent alcohol intake. So on to the PEF fundamentals. This figure is a figure that we made for a review that we did for Journal of Hepatology, and it shows you the metabolism of alcohol in the human body. So very briefly, we have the metabolism of alcohol going on in 3 different pathways. So we have the oxidative pathway that goes on into the liver. So we have 3 different main types of enzymes that break down alcohol into acetaldehyde and the acetate, which we have circulating in the blood. Then we have some direct excretion, so that either being in the sweat, the breath, or the urine. That's around 5%. And in the middle, we have the non-oxidative pathway of the metabolism of alcohol. And this is where different circulating enzymes are degrading ethanol into different types of compounds, one being ETS or ETG that we can measure in the urine. ETG is also something that we can find in the hair. But finally, we also have PEF, so phosphatidylethanol, that is formed directly on the basis of ethanol present in the bloodstream. So here we can really have a direct measure of ethanol intake. So compared to many of the indirect biomarkers that I showed you just before, the indirect biomarkers can also have a range of other causes for being either elevated or lowered. This is at least in theory, not the case for PEF. So it's only in the presence of alcohol in the bloodstreams that we will see the formation of PEF. And what's really the origin of PEF? Because it's, at least within hepatology, I believe only pretty recently that we have started to talk about PEF, so phosphatidylethanol, as a direct biomarker of alcohol intake. But the reality is actually that it was maybe back in the 1983 that this small molecule was actually first identified. So this was by colleagues coming from Sweden, where they first found it in rat organs after ethanol exposure. And from there on, it has kind of snowballed into how we use PEF today. So I mentioned it briefly already, but what is really important when we talk about PEF is that it's very specific, a specific enzymatic reaction that is happening only when we have alcohol in the bloodstream. So whenever we have alcohol intake, it's absorbed throughout the GI tract up from the gastric part and down through the different intestines. Then when it's coming into the bloodstream, it's where it's bind the red blood cells. So in the cell membrane of the red blood cells, we have phosphatidylcholine as one of the most abundant lipid membranes, or membrane lipids. And it's in the red blood cells that when we have ethanol present, that the phospholipase D or PLD enzyme catalyze this specific biochemical reaction where we actually see the ethanol binding to this membrane lipid, so we can find the ethanol present or in the membrane of these red blood cells. So this is really how PEF is formed in the first place. The second, and this is also something we will come back to later, how it's degraded is first of all through the natural degradation of the red blood cells. So this is the same pattern that we see when we measure HbA1c in patients with type 2 diabetes to have the long-term blood sugar. It's also dependent on the hemolysis, so the turnover of the red blood cells. A second important thing of PEF compared to the HbA1c in comparison is, since it's a membrane lipid in the red blood cells and not a protein per se, it's also very dependent on the membrane lipid renewal that is continually ongoing in the red blood cells. So these are kind of the two main factors that determine the degradation of phosphatidylethanol. And what also really makes the case for PEF compared to many other of our biochemical biomarkers of alcohol intake is really the detection window. So we can employ a rule of three for three different direct alcohol biomarkers. So for urinary ETG, we can, at least in theory, say that you have a detection window around 3 days. For phosphatidylethanol, it's 3 weeks. And for the scalp hair ETG, it's 3 months. So either the 3 day or 3 months can in some clinical scenarios either be too short or too long. And that's also why it's very convenient that we have phosphatidylethanol as a circulating one, that we can at least in theory and approximately have an idea of the alcohol intake within the last 3 weeks. And what's also an important thing to take away from this is that when we look at PEF in the clinic, we just talk about PEF as a membrane or as a abnormal membrane lipid in the red blood cells. And actually, there has been identified 48 different homologs of PEF. So 48 different types of way that the ethanol can bind to different membrane lipids to form this binding between the membrane lipid and ethanol. However, it's most often in the clinic only one of the homologs that we measure. We normally measure the most abundant one, and that's the PEF homolog 160181. So that's one thing that's very important when you interpret a PEF and when you have the result from the lab, is that you actually make yourself aware and make sure that the lab are aware of which one of the homologs that we measure. And what has recently also made, PEF something that we use in everyday clinic is really the revolution that we have seen with measurement techniques that has made us able to make very sensitive measurements, putting PEF in a spot where we are at least able to measure PEF in quantities that are clinically relevant. So I showed you already that the molecule was first discovered back in 1983. And from there on, there has been refinements of all these different measurements techniques. So not going into details, but back in the start when it all started, it was light scattering techniques that they used. It then went onto a mass spec platform, first a single and then tandem mass spec, which has meant that when we talk about the lower limit of quantification, so what is actually, the lowest unit that we can measure with a certain degree of, specific degree of certainty, it has evolved from 700 nanograms per milliliter back in the late 90s up until 1 nanogram per milliliter with the most advanced machines that we have available right now. So this has really made it possible to not just use this in a research setting, but also put it into use in the clinic. When we can measure PEF at so low quantities is actually where it also makes clinical sense. So that was the PEF fundamentals, and then we will go on to how we should actually interpret PEF values when we have a patient in front of us. The first thing that we think of when we talk about PEF are cutoff values. So there are many different cutoff values proposed for PEF. Some of the most commonly used ones are the ones which stemmed from a consensus that was done back in 2022 in Basel. And that was where this group of experts came up with this, you could also say, rule of 2 and 200 or 20 and 200, where we say that if it's less than 20 nanograms per milliliter, it's the equivalent of abstinence or very low alcohol intake. If we have patients who have a PEF value of 20 to 200, it's considered moderate use. And when we have a PEF value that exceeds 200 nanograms per milliliter, it's normally something that we see in patients with a chronic excessive alcohol overuse. So normally something that we see in patients who, for example, have alcohol-related liver disease. But bear in mind that these are not the only cutoffs that are used around in different clinical settings, but also in different research settings. Sweden, I told you earlier, they were the ones who actually discovered this molecule. They also have their own cutoff values for PEF. So instead of the 20 nanograms per milliliter for the lower part with abstinence, they employ the 35. And then they have the upper bound of 210 instead of the 200. But what's really important when we talk about PEF and steatotic liver disease is that none of these proposed thresholds or cutoffs were derived or were made on the basis of the steatotic liver disease nomenclature, where we divide patients into MASLD, MADLD, or ALD. So they may not be necessarily one-to-one compatible with the thresholds that we have in the steatotic liver disease nomenclature. And that's something that's really important to bear in mind, both in the interpretation of research that we have, but also when we see patients and when we have to subclassify these patients according to the SLD nomenclature. And this is also one thing that I would like to show you here, is that PEF is really tricky in the way that it's not necessarily just the number and then you have the answer for your patient. It's really more complicated than that, and it's more complicated than that due to the dynamic nature that we see of alcohol intake. So compared to the blood sugar, which is constantly at some level in the blood, it's not necessarily, at least for most patients, not the case. So we can see different drinking patterns actually affecting the PEF values. So the first study I'll show you here on the left-hand side are actually the results from a German study where they had participants coming in for a controlled binge drinking episode. So they tried to target the patients to have a blood alcohol concentration of around 1 gram per kilogram of body weight during 1 to 2 sessions. And you can see the results from here, where you on the y-axis have the quantity or the concentration of PEF, and on the x-axis you can see time. And what's really striking is that even though the investigators tried to target the same blood alcohol concentration, which at least in theory should be leading to the same PEF values, the resulting PEF formation from this controlled binge drinking episode was anywhere in between 60 nanograms per milliliter to 220. So you can see this is a very wide gap. So if you expose one patient or one participant to this intervention, the resulting PEF could be one thing and a totally different one from another patient. The second thing is when we look into continuous alcohol or continuous daily consumption of alcohol, because this was a 1 to 2 time binge drinking episode that I showed you first. Here on the right-hand side is a relatively new study that came out of Sweden, where they tried to assign participants into either drinking 1 unit of alcohol per day or 2 units of alcohol per day. And what you can see from this is that the range of PEF after 2 weeks is anywhere in between 7 nanograms per milliliter to 30 nanograms per milliliter if they were assigned to drink 1 unit a day, whereas it was anywhere in between 7 to 65 nanograms per milliliter for those assigned 2 units a day. So again, you can see, even though we can see a trend of higher values in those assigned 2 units a day, it's very different from person to person. And that's one of the key takeaways that you should take away from this, is that this data at least suggests that we have very high inter-individual variability in the formation of PEF. And as I mentioned earlier, one of the big pitfalls or one of the issues or gaps that we have in our field is that the different types of cutoff are not necessarily derived from our patients. So back in 2014, a US study actually tried to look into the diagnostic accuracy of PEF cutoffs in patients with chronic liver disease, so in the patients that we see in our clinic. And what you could see from here is that if you have different drinking states of either any drinking, so for the last month, if patients reported any drinking, if you had a concentration of PEF of either 8 or 20, that could result in pretty nice sensitivities, but importantly, very high specificities, meaning that a false positive result, so having an elevated PEF but not being drinking, is very, very unlikely. And on the other hand, if they try to look at a cutoff of 4 drinks a day, so patients reporting, I drink more than 4 drinks a day, which is what we see in the boundary between mid-ALD and ALD, it was cutoffs with very high sensitivity. So this cutoff, or these two cutoffs, the 20 and 80, captured more or less every one of the high-consuming participants when we employed these thresholds of 4 drinks a day. So these are some that we should at least bear in mind as cutoff that we can use in our patients with chronic liver disease. So what this figure shows you, or what these two figures shows you, are really the dynamics of PEF over a month of different drinking patterns. What the data already told us, but what is maybe put up more schematically here. And there are 3 things that you should think of when you have a PEF value. So one thing is quantity. So how much does the patient drink? That's one thing. But 2 other things that are very important in the interpretation of a PEF measurement is the frequency. So how often does your patient drink? Is it once a month, once a week, or daily? And secondly, from you did the measurements and from the patient had the last drink, how long time were there in between those 2 time points? So the recency of drinking. These are all 3 things that can, at least in theory, affect our interpretation of the PEF result. So think of quantity, frequency, and recency when you talk with patients about PEF results and the self-report. Right. And finally, think of what could potentially, beyond the drinking, affect the PEF result or the PEF measurement. There are many different studies who have tried to identify the different confounders that we have of the PEF results. I would maybe say that the 2 most important ones, and where we have the most reliable data and also the most biology behind it, is first of all the red blood cell turnover. So if you have a patient with hemolysis, so a rapid red blood cell turnover, that could actually result in a false negative PEF. So you would have a faster turnover of the red blood cells, resulting in a lower PEF measurement than what you would otherwise expect. Secondly, the body composition is something that's very important. And the body composition is important because it's something that determines the peak alcohol blood concentration from the same amount of alcohol. So alcohol is only distributed into the fluid or the water compartment of the body. So if you have a patient with a relatively high water body compartment, the resulting PEF will be lower compared to one who will have a lower total body water compartment, where the PEF will be the resultingly higher. So those are the 2 ones where I think we have the most evidence and science behind it, the red blood cell turnover and the body composition as potential influencing factors of a PEF result. And then on to how PEF performs across the patients with steatotic liver disease, so in the SLD spectrum. This figure is what I also showed you just before, really important with the MASLD, mid-ALD, and ALD, about how we subclassify these patients according to the alcohol intake. So the question is really, how can we use PEF in the management of the steatotic liver disease patients? So what we have had pretty good evidence behind right now is that when we put our PEF on top of self-report in a clinical interview and audit C, we see a substantial reclassification of patients with steatotic liver disease. So on the graph here on the left-hand side is from a study that we did from our group that was published in Lancet Gastroenterology and Hepatology last year. So this was a study of having close to 2,000 patients with steatotic liver disease, where we asked them in a clinical interview about the alcohol intake and classified them into MASLD, MAID-ALD, and ALD. We secondly also handed them out the Audit C questionnaire. So I guess most of you are aware of Audit C. It's 3 questions asking about alcohol consumption habits. And there you can have a score ranging from 0 to 12. And you can have if you categorize it, a value that is either low, intermediate, or high. And when we did this, so the clinical interview in the Audit C and put the PEF on top, it was evident that if we used the 20 nanograms per milliliter cutoff, we actually observed up to 39% underestimation of the alcohol in the MASLD population. So all the patients that you see here, either in red, orange, or the light orange, are the ones who should either be reclassified as MAID-ALD and ALD. Secondly, we also observed that the patients who, based on the self-report, should be classified as MAID-ALD, many of these patients actually had a PEF that was above the 200 nanograms per milliliter threshold, so something that was more indicative of ALD. And finally, what's maybe also very important is that for the patients who self-reported an alcohol intake equivalent to ALD, we only observed, or more or less only observed, very high PEF values, indicating that over-reporting of alcohol is really not an issue in an adult population. It may be, in your children's high school class that they can over-report alcohol, but not when you see a patient in the clinic. That's not something that we should be worried about, at least. And I think what's very importantly is that it's not only us who have, shown this. We also have other studies, this one published in Journal of Hepatology last year, where they had patients, community dwellings from San Diego area in the US, and they observed when they put PEF on top of the self-report, a 4-fold increase in the diagnosis of MAID-ALD and a 3-fold increases in the diagnosis of ALD. So really something that reaffirms us that this is not something that is, nation specific. It's at least something that, we see in the Western part of the world. And the same is actually, for this is just a registry-based study that comes and originates from Sweden, where they had more than 6,000 patients with either confirmed or presumed MASLD. And when they checked their PEF measurements, it was evident that 20% of those with presumed MASLD maybe had PEF values indicative of MAID-ALD, and 14% actually had PEF levels indicative of ALD. So I told you about, the number of 39%. Here it adds up to 34. So roughly we can say that it's in the order of 1/3 of the patients with MASLD that we normally see that who should probably either be classified as either MAID-ALD or ALD. So that was kind of the diagnostic part. The second part is also if PEF have prognostic importance. So this is another Swedish study that was published in Hepatology Communications a few years back. And here they had many patients with MASLD with dual biopsies many years apart. So here you can see the 82 patients that they have, where they either grouped them into having significant fibrosis progression, meaning that they, between the 2 biopsies, either progressed 2 fibrosis stages or developed hepatic decompensation, or those who did not meet any of those 2 criteria. And what was evident from this, and what was really interesting from this study, is that when you looked at the self-reported alcohol intake between these 2 visits, they were at least not statistically significant different for the ones who progressed, have significant fibrosis progression compared to those who did not. But what was really standing out as something that predicted or was associated with significant fibrosis progression was the PEF value, or the difference between the PEF values between the progressors and non-progressors, and also the participants who reported binge drinking. So that was something that stood out as statistically significant different results between the two groups. And it's also been shown in bigger studies that PEF have prognostic importance. So what we look here on the left-hand side is when patients are classified according to PEF, you can see a steep line for the ones who have a PEF value indicative of ALD, where they have a 5-year risk of any major adverse liver outcomes of more than 20%, compared to those who have MASLD and a PEF, which is equivalent to less than 35 nanograms per milliliter, where the number is closer to 2.5%. And you can actually see that this is an exponential relationship. That's what the thing on the right-hand side shows you, is that you can have from very low values up to very high values, where you see an increased hazard ratio or risk of these major adverse liver outcomes for patients with steatotic liver disease. But what we have at least shown from our group is that when you have a single measurement of PEF, you have some prognostic discrimination with that. So you are able to tell apart patients if they will progress or not for a certain period of time. But compared to different markers of liver fibrosis, for example, you can see both PEF and self-report in this case does not perform very good. And at least over time, the prognostic discrimination, diminish rapidly compared to the other ones. So this was a study that we did in patients with alcohol-related liver disease, so those who self-reported an excessive or history of excessive alcohol overuse. And from the baseline, or at least 6 months from the measurement, it had a nice area under the curve, both PEF and self-report, but you can see after 1.5 years, it was close to 0.6 for PEF and close to 0.5 for the self-report. So really not good compared to the liver fibrosis biomarker. And what this really tells us is that this is probably something that reflects the dynamic nature of alcohol intake. So if you in one period of your life have a very excessive alcohol overuse, does not necessarily mean that you will have it throughout, your whole life. It's something that can vary a lot and probably very different or dependent on different life situations or phases that people and patients go throughout the lifetime. Nevertheless, when we in the same patients actually tried to see if repeated testing could do something, we confirmed that it could. So when we have those from the baseline to the follow-up who actually increased the PEF values, they were also in a markedly higher risk of develop hepatic decompensation compared to those who did not. So that was something that confirms us that you may not be able to rely on a single measurement, but if you do it repeatedly, and I would say in between 1 to 2 years apart, it's really something where you can, track it over time, and you can also pinpoint out those who are in a higher risk. So those where you can see an increase in the PEF, where they're probably also more likely to experience unfavorable outcomes. And what's really also something that has been discussed is whether we can rely on this PEF in patients with cirrhosis. So we know there are many different pathophysiological or pathophysiological mechanisms going on when patients, transition into cirrhosis. But this study, the origin from Belgium, had at least shown that we have good diagnostic accuracy in patients with alcohol-related cirrhosis. So for the 3-week alcohol use, it was very good and nice at both detecting any alcohol overuse, increased alcohol use, or excessive alcohol use, and also probably complementary to the other alcohol biomarkers that we have available. And finally, for this, patients with SLD and PEF is in the transplant setting. So in the patients that we have on the waiting list for transplant. And this is also something where I really, first of all, think we should make up our mind when we should use PEF in this population, but also in which group of patients. So this is a study published a few years back originating from Germany, where they looked at patients who were on the waiting list for liver transplant. and they tested both the urinary ETG, the hair ETG, and the PEF. And what they showed was that the likelihood of having a positive PEF result when being on the waiting list for liver transplant was just as likely for those who had alcohol-related liver cirrhosis compared to those who had cirrhosis of any other etiology. So this probably challenged our assumption of, who should be the ones that we should test with a PEF prior to transplant, because no matter if it's, one etiology of the other, alcohol intake, both preceding the procedure but also after the procedure, is something that will probably, lead to unfavorable outcomes with graft rejection and then, having the need of a new transplant in the future. So it's something where we really need to, make up our mind whether we should test nobody or test everybody when it comes to at least a transplant setting. So finally, for the last 5 minutes, I will talk about how we can put PEF into practice based on the state of the current evidence that we have. So this is from the review that we did in JHAP, and what I really would like you to take away from this figure is the concept of triangulating the alcohol assessment. And what we mean by triangulating the alcohol assessment is that PEF is not meant as a replacement of asking the patient or talking with the patient about alcohol interview. This is rather something that is complementary to the self-report. So when we talk about triangulation, we really encourage everybody, of course, both to have a self-report in a clinical interview, sitting in front of the patient talking about alcohol. Secondly, also do the audit C. Why do the audit C? Because it's very simple, it takes a very short amount of time, and it's something that gives us pretty granular insights into drinking patterns. So does the participant or patient engage in binge drinking or not? This is something that we can at least have an idea from when we use the audit C. And then, of course, finally, the PEF. Because when we have all these 3 different elements, we can, with a bigger degree of certainty, actually say whether the steatotic liver disease or whatever kind of liver damage that we have can be attributed to alcohol or not. So don't replace, PEF with the self-report. Use it on top of the self-report. But we still face a lot of issues with PEF when we say that we should triangulate and just use PEF with audit C and the self-report. And this is actually a questionnaire that was done in Asia. So for colleagues from Asia who first asked, what were the preferred alcohol biomarkers if they were available. And the majority actually said that they would prefer to do a PEF test. That was more than 50%. But what's really striking and what's really still a challenge here is that what was the current practice to assess alcohol use for these respondents? And you can see here on the right-hand side, then it was actually less than 10% who actually use PEF now. So we have a big issue of both, the cost of testing when we want to do a PEF test, but also the availability in a broader sense. So do we actually have the machinery in all different regions of the world to do a PEF test? Probably not. They may be coming, but not at the moment. So when we have this issue of not being able to test everybody, the question becomes, who should you then test? So we did this in one of our studies based on the data that we have. So we tried to come up with a kind of algorithm telling us who should we test. And we can maybe start with those who here self-report a very high alcohol intake. So if you self-report the equivalent of alcohol-related liver disease, so more than 50-60 grams per day for women and men respectively, it doesn't make sense to do a PEF because over-reporting is very rare, and it will be very unlikely that it will change your management of this patient when you have a skyrocketing high PEF result. Instead, the ones who have med-ALD, so an alcohol intake in between, a self-report at least, and then those with a low self-report, but something on the audit C that points out that they may engage in binge drinking, or they may, have a different frequency of drinking. It should also be patients where you should consider at least to order a PEF to get a more granular, a better idea of what is the role of alcohol actually in this patient. And colleagues from the US again have also come up with another proposal for how we could select patients for PEF testing. So this is the model that they call MAPI. So based on routine blood samples, so sex, MCV, GGT, HDL, and HbA1c, they put together a probability of a high PEF. So again, for those with a very low alcohol intake, if you try to use this MAPI and have a score or probability above 0.09, it's something where you should probably suspect med-ALD and ALD, and you should think of ordering a PEF test in these patients. So this is the second model that I believe there's an online calculator available to everybody. So this can be another way of trying to select patients for this. And then finally, I will only use 2 minutes on the last slides, but this is probably the most important thing when we talk about this in a clinical sense. So how do we actually communicate with the patients when we have something like this? Because when you measure PEF, we measure behavior, and we measure behavior that patients are not necessarily always interested in disclosing to us, whether they, do it or not, engage in drinking or not. So I think I've just come up, with something language that I use myself when I talk with patients about a PEF. And the first thing is that you should really frame the test before you use the test. So pre-test, talk about the PEF with the patient and really, explain these patients that PEF is a routine biomarker for liver care. You could see it as an equivalent of LDL for heart care. We use it for everyone. Of course, only say it if it's true with steatotic liver disease, so we can give you the right diagnosis. This is something, that informs patients that, okay, I will actually have this test tested and it's part of a routine panel. Then you should, of course, also consider how should you, put your language if you have a positive result, but the patient denies drinking. One way of framing it can be that this value suggests more drinking than I would expect from our conversation. So please help me understand what's been going on. I would like to support you and not catch you. So that's really important. So this is not a lie detector. It should not be framed as a lie detector. It's something that should be, help to identify in the single individual what's the role of alcohol, and of course motivate and help people change behavior if they're willing to. And secondly, also, of course, a negative result is also important to communicate. So we can also assure the patient here that the PEF confirms what you've told me, and that's really useful because it supports the progress that you've made and the plan that we already have. So, keep these things in mind when you want to communicate it. And finally, just also be aware of the local legal challenges that may be when we measure behavior. That is currently not a big issue where I come from in Denmark, but I can tell you in Sweden, it's a very big thing because doctors are mandated to report it to the authorities if patients have too high measurements of PEF. They can potentially have their driver license withdrawn without not having been intoxicated while drinking. So it can potentially have legal ramifications. So I don't know how it is in Italy, of course, but keep that in mind once you order the test and once you have the result. So the 5 things to leave with from my talk is that PEF is a direct blood-based alcohol biomarker with a very useful clinical detection window, so use it. Think of quantity, frequency, and recency when you try to interpret the PEF result. Rather than thinking of a specific number, think of zones when you try to interpret a PEF value. So you can use the 20 to 200, more than 200. You can also decide on other ones, but just think of it as zones and not, as one single number. And importantly here, it's more multiple measurements with a trend that tells you something rather than a single measurement. Remember to triangulate the alcohol assessment. So remember that PEF is not a replacement for the self-report, but an addition to the self-report. And finally, frame the test when you talk with patients. Communicate clearly and be, of course, aware of what potential legal implication that it can have if you have a positive result coming back. So that was it for me. I think and hope we still have some time for questions and discussions. At least for now, I would just like to